Hello. Hello. A very good evening to one and all present here.
Check, check, check. Hello. Good evening, friends, and welcome back to the Thursday evening teaching sessions brought to you from Lokmanya Tilak Municipal Medical College, Sion Hospital, Mumbai. We once again thank the authorities at Sion Hospital for allowing us to conduct these classes and to Alchem Alpha Max Division for giving a scientific grant to webcast these classes. The first case is being presented by Dr. Rutuja.
A very good evening to one and all present here. "11-year-old boy, second by birth order, born out of non-consanguineous marriage, resident of Kalyan, hailing from Sangli, Hindu by religion, Gosavi by community, informant being mother who is reliable, was brought with complaints of increasing tiredness on activity since 5 years of age and blood in sputum since 6 days. This child was apparently alright 5 years ago when mother noticed that he gets tired easily on playing with children of the same age group and is accompanied by difficulty in breathing and left-sided chest pain, which is aggravated by further activity and is relieved on taking rest. Child continued to have these symptoms in a progressive nature, as in initially he used to get tired on playing for about 15 to 20 minutes, but later on, over a period of 1 year, he used to tire out even on playing for 4 to 5 minutes. Child would attend school regularly, however, he preferred not to play. Child also complained of palpitations on exertion in form of increased precordial activity, which was again relieved on rest. For the above complaints, child was shown to a local private practitioner in Sangli 5 years back. A chest x-ray was done and was told to have some heart problem, was started on some medications. However, he did not take the medications and no further medical advice was sought later. These complaints have now progressed, and since the past 7 to 8 months, child has difficulty in breathing even on normal day-to-day activities like going to toilet, talking, thus causing functional limitations. However, the sleep cycle of the child is maintained. Mother also noticed blood in sputum since 6 days prior to admission, painless in nature, about 1 teaspoon in quantity, staining the cheek and the pillow while sleeping. However, there was no bleeding episode throughout the day. There is no history of fever, rash, joint pain, no history of recurrent cough and cold, no history of vomiting, abdominal pain, abnormal bowel movements, no history of any local trauma or dental procedure, no history of blood loss from any other site, no history of bluish discoloration of skin, no history of swelling of body, no history of COX or COX contact, no history of sudden death in family. Past history is not significant. There is no history of similar complaints prior to 5 years of age and no any other medical or surgical illnesses. No history of any blood transfusions. ANC and birth history wise, it was a spontaneous conception at 22 years of age, received iron folic acid tablets, no history of taking any other drugs. 3 antenatal USG scans were done, was told to be normal, no history of any fever with rash, PIH, GDM in mother. The delivery was full term, normal vaginal delivery. Baby cried immediately after birth with a birth weight of 2.5 kg. No history of any neonatal jaundice, no history of any NICU stay. Discharged on day of life 3. Immunization wise, the child is immunized till date as per national immunization schedule. Developmental history appropriate for age. Studies in 6th standard with good scholastic performance. Dietary history is deficient in both calories and proteins. Family history wise, the mother is an ICP positive, diagnosed 5 years back. She is on regular medications. However, all the children were screened and they are negative. No other significant family history. Socioeconomic history, they belong to lower socioeconomic class according to modified Kupus-Kwami scale.
Okay, so who will start analyzing the chief complaint? Around 6-year-old boy, 11-year-old, 5 years back. So 6-year-old boy complains of tiredness while playing. What are your thoughts?
Could be a sign of anemia, one of the commonest causes. Nutrition.
Okay, so one cause is anemia. Then anything else?
Sir, there might be three system involvement. Three system might be involved. First is CVS system, or respiratory system, or blood. It might be anemia.
Okay, very good. So hematological, respiratory or cardiovascular. Now, how will you separate them out?
We have to ask further history.
Yeah, so ask.
Negative history.
She has given you some history, it is there, and what else you want to ask and how will you separate it out?
Can it be neurological also, muscular? You didn't say, right? You said only three systems. Rightly so. Why not muscular?
But then, sir, in case of neuromuscular, like problems with the day-to-day activities, like waking up from sitting position, like features of more of proximal myopathy, these should be present. But here, I couldn't find any of such features.
No, but first tell us which neuromuscular disease will you get tired while playing. First tell us that and then
That's the only question. We agree with you that we are not thinking neurological, but why are we not thinking? What is the complaint when there is a muscular weakness? Is it tiredness or is it something different?
Cramps, muscle cramps.
Sir, weakness will be for day-to-day activities like combing hairs and getting up from sitting position, not during playing and exertion.
Relieved on rest.
Usually muscle weaknesses come with complaints of what? Inability to do something rather than not willingness to do something. Correct? Or they will come with frequent falls. If you are thinking of ataxia, if you are thinking of muscular weakness, or if it's a neuromuscular weakness, maybe you have some diurnal variation, etc. But the point we are trying to convey is that when there is a neurological cause, it's a inability to perform, whereas here the desire to perform is there, but they are not able to perform because they are getting tired.
So now debate between the three: hematological, cardiac and respiratory. Come on, some points which are already there or which you want to ask.
Points like palpitation on
Hold close.
points like palpitation on exertion, increased precordial activity points toward CVS cause of
Okay,
exertion.
so it points to a CVS cause. Now we'll discuss. So can anemia also cause palpitation?
Yes, sir.
Why?
There is hyperdynamic circulation.
Okay. So now how will you differentiate? This is CVS or hematological?
The duration of the progression.
Very good.
This is a chronic, means it is gradually increasing duration.
Yes. So chronic is gradually increasing, yeah, but how will the duration differ in anemia and in cardiovascular?
Anemia will be more sort of acute.
So what kind of anemia do you expect this to be, which will lead to tiredness?
Nutritional.
No, means in terms of characteristics. So will it be a status quo anemia with a hemoglobin around the same all the time? Will that person be tired, or who will be tired?
Progressive.
Very good. So it has to be a progressive anemia, and progressive over a relatively short period of time to say that he is getting tired, right? The more chronic it is, the more compensated the patient will be. So it will not become very obvious in routine activities, right? Okay, then what are the other differences? Who will get breathless out of all these three? Respiratory person who feels tired while playing will get breathless. Yes. Cardiac will get breathless. Yes. Anemia will get breathless. Yes. So what is the difference? When will the anemia person get breathless while playing? When it is severe and is on the verge of failure, cardiac failure, then they'll get breathless. So between the three, the cardiac and the respiratory will get breathless faster, in terms of time frame. What else? So what will happen as the anemia progresses? No, symptoms. Will they complain of anemia? Can they complain of anemia, parents?
The initial.
So they may complain that he is looking very pale. Okay, that is one. Second,
Irritability.
okay, irritability is in a younger child, 5-6-year-old, it's difficult. Okay. So will an anemia child want to go to play? So he'll be tired. So that tired as in this anemia child may then not want to go to play only. He's feeling tired even at rest. Whereas the cardiac person initially at least will not be tired at rest, will be okay, but activity will make the child tired. But these are small differences that you will have to try and ask and pick out. Okay? And of course, as disease progresses, the cardiac person will also be tired at breathless at rest and not want to play, as is there in this history, and so also the respiratory person, right? Okay. Now, this palpitation history which you are saying, what other questions will you ask in palpitations?
Whether it is palpitations at rest or palpitations on exertion.
Right. So what difference does it make to your interpretation?
The severity of the symptoms, the degree of the failure.
Provided it is cardiac. But before that,
Differentiating between cardiac and respiratory.
or why should a respiratory person have palpitations? Why should an interstitial disease who's feeling tired on playing and
Palpitations on exertion, sir, will mean that at rest the body is able to provide or compensate the metabolic demands, but on exertion the body is not able to fulfill the demands of the body.
So what I mean is that, see, if you suddenly climb a flight of 7 stairs, will you get palpitations? So palpitation only on exertion could literally start from normal or could be a anemic child who's being asked to undergo a stress and therefore gets palpitations, or a cardiac child. Okay. So you will have to start from there. Then that exertion also has to be accustomed or regular exertion or unusual. So if we climb 7 flights, suddenly it is unaccustomed exertion, and if we get palpitation, it's normal, right? So that is one thing about rest and exertion. What else do you want to find out? You should try and ask all these if the child is older about palpitation. So what else do you want to know?
So if the child is old enough, he can mention whether it is rhythmic or not.
Excellent. So you must always ask that question. Rhythmic or irregular. Why? Come on, you are thinking of something, na? When it is palpitation, what are you thinking of in your mind?
It could either be a compensatory mechanism or some arrhythmia.
So that's the physiology behind it. Anatomy is, it's the heart. So now regular would be, like you said, hypertrophy of some ventricle or whatever, volume or pressure overload. And irregular would be a arrhythmia. Then next, what can you ask?
Is it continuous or is it episodic paroxysmal?
Excellent. So episodic paroxysmal is?
It could be a arrhythmia which has come during that time, like a PSVT.
So supraventricular tachycardia. Very good. Then?
If it's associated with any giddiness or syncope.
Very good. So that also, what does that tell you?
Decreased blood flow to the brain.
Very good. So it is at that moment of that irregularity, the cardiac output is falling drastically if there is history of giddiness. So it tells you that. Okay.
Anything else in palpitation? Forget the first part of the history. Just we are focusing on history of palpitation. Anxiety? Okay. So episodic, if you say it's anxiety. In persistent, anything else, any other history you want to ask?
Can be hyperthyroidism.
Very
So,
good, excellent.
history
That's
of
what I'm asking. So
weight
it's
loss
good to
and-
keep your options open, because sometimes palpitation will be the only presentation from the parent side, and when you from the patient side, and otherwise no. Also, when a 5-year-old complains of palpitation, you tend to take it more seriously. I mean, that's definitely abnormal. Okay.
Okay, so now in this child, given this kind of a progression, what do you think? Is it anemia, or is it heart disease, or is it a respiratory disease?
So disease is progressing over years. So less likely anemia. It will be respi or severe cause only.
Between the two, between respi and CVS?
More likely.
So as the disease progresses, what will happen to the respi person? A disease which is causing this person to become tachypnic or hypoxic while playing. What is that kind of a disease, and as it progresses, what will happen to this person? What kind of disease will make him do that? Asthma? Pneumonia? So what kind of disease will make him breathless while playing? Respiratory disease. Interstitial lung disease. So as it progresses, what will happen? Symptoms. Breathlessness at rest or tachypnea at rest, right? Whereas that will happen in a cardiac disease when he is in continuous failure, right? So then you will expect other symptoms there like edema, etc., and cough and so many other things, right? So this is more likely to be
Cardiovascular.
cardiac. Now in cardiac, congenital or acquired?
Some form of acquired disease.
Why?
Uh,
So, which brings us to the question, which congenital heart diseases can present later, not at birth?
ASD.
Okay, when does it present?
Mostly ASDs are asymptomatic, but adolescent periods like around 10 to 12 years age can also present ASD.
30 to 45 years.
Usually third decade or second decade, if they have crossed that initial newborn period, right? What else? Which other diseases can present congenital heart disease later?
Mitral valve prolapse.
Mitral valve prolapse will present as what? Present as clinically as
Syncope and chest pain.
syncope and chest pain. Okay, maybe. What else? Come on. Something which can present at any age from infancy to fourth, fifth decade or whenever.
When you're thinking of congenital heart disease,
VSD.
don't stop at only shunts. Think about other conditions. That's a hint for this particular thing. Also, if somebody asks you how does MVP present, you can say it can present with an SPE also. Okay, it can present with failure if there is a rupture of the tendon, but basically it won't present as a dyspnea on exertion unless there is associated cardiac failure because of the regurg.
Come on, which other disease are we talking of?
Think
Which-
about some not so dangerous conditions. Some stenotic lesions. Which ones? Pulmonary artery stenosis. He's just asking you what can be asymptomatic for a long time. I'm not saying which is asymptomatic but presents like this, right?
In one person, it was diagnosed when they entered MBBS and they were asked to take each other's BP. When they were first taught on the first day of entering medical college, take each other's BP and learn how to take BP, that condition was diagnosed.
Lower limb BP or upper limb BP?
Very.
Coarctation.
Coarctation of aorta. Correct.
Okay, so which congenital heart disease can present like this at 5-6 years of age? I am asking you this because when you are going to argue in exam why acquired, your most likely answer will be that there are some congenital diseases which can present later, but they have classic patterns. So ASD in second, third decade, coact will not present like this with dyspnea on exertion. It may present as something else, hypertension or acute cardiac failure or whatever. So you will say that this looks less likely congenital and more likely acquired.
What is the age of the patient today? 11.
11 years.
So at 6 years was a symptom was noticed first time.
Yes, sir.
Okay.
What else is there in the heart? There are valves, there are shunts. What else is there? Heart itself.
Muscle.
So can it be something to do with heart muscle itself?
Cardiomyopathies.
Will it present silently? In the beginning it's not there and gradually progressive. Over the years,
Pericarditis.
without actually, even if he goes to a physician, he will not be able to diagnose that, because according to him, if there is no murmur, there is no heart disease. So there is no murmur, so there is no heart disease. The child is slowly progressive. So in this scenario, we will have to keep that in mind. Just a thought back that increased, easy fatigability is as a result of, it can be a symptom of muscle disease. Muscle get tired. Why do they get tired? Because they are not getting enough energy. Where is the energy coming from? Energy is coming in the form of glucose or oxygen. Glucose will talk of metabolic disease. Oxygen will talk of hypoxic conditions, including cardiac conditions. There can be primary muscle disorders, as he just mentioned, but they will not come so much with breathlessness, but they will come with inability to do some function. I'm not able to get up, I'm not able to climb, that kind of a thing, telling you more about power rather than yeah. And then as we discussed that after you come to that, you have the cardiac, respiratory, as rightly stressed, palpitation perceived by parent, and then tachycardia or increased cardiac activity are two symptoms which directly point to a heart disease. And of course, breathlessness over a period of time will be breathless at birth. So we start on a very wider base and then go down narrowing, and when you come to the heart, we often tend to forget the cardiac muscle because it's relatively uncommon. But in this particular scenario, it has to be kept in mind.
So we'll say that all those things we cannot rule out, but then by common this thing may be acquired heart disease more likely. Now in that, which valvular heart disease in acquired? So with this history, which valve?
Just to complete the list of sorts, as we said, ASD, even VSD may not present clinically for few years. So at 6 years of age, if you take a cutoff, then ASD, VSD, PDA, coarctation of aorta, pulmonary artery stenosis, all these can be asymptomatic till then. Even TOF with mild PS can continue to be asymptomatic unless you are talking about growth failure and other things which you are also looking at. So there can be not so silent but otherwise missed on signs.
What is the presentation of primary pulmonary hypertension? Easily missed, nothing is found. How will it commonly present? I have not seen too many cases, of course, but pardon me? So like a cardiac failure or breathlessness?
Cardiac failure, edema, ascites.
Why not like breathless?
Because from right atrium backflow is
Yeah,
there.
so you are probably dealing there, the load is more on the right side rather than the left side. So he may present with more like a congestive cardiac failure rather than left ventricular dysfunction, especially ejection fraction being affected. Okay.
Yeah, so now this is which valve you think?
So more likely involvement of the left side of the heart.
Very
Could
good. So
be.
mitral or aortic.
Aortic.
Okay. Now between the two, can you further try to decide? So what other symptoms do you have? Before the bleeding, you had some chest pain, no?
Yes.
So can you discuss that? What was the chest pain nature, etc.?
Chest pain was intermittent in nature, more like of stabbing in nature. The duration was, means he used to play, and while playing after a period of time he used to get the chest pain which was stabbing in nature, and there was, means it would.
So how do you
get
analyze this
aggravated.
chest pain? So in children, commonly if you get a complaint of chest pain, what should be your approach? Come on, what is the first question you should ask?
Sight.
So site of the pain, where is the pain? Why is this important?
For localization. of
So
the
tell
symptom.
me different sites and different localizations.
Epigastric pain can be because of abdominal origin, or it could also be because of CVS origin. Left side of the chest radiating to the axilla and the left shoulder, more likely pointing towards the cardiovascular system.
Yeah. So so epigastric is fine, but when we talk of chest pain, one of the commonest is midline chest pain, which is retrosternal, which is esophagitis. And in fact, it is one of the commonest causes of chest pain in children. So in children, cardiac and respiratory causes of chest pain are not so common. So that's one. Then you said cardiac, which could be precordial, and respiratory would be on either side.
Pleuritic
So
pain.
pleuritis. Now it could be secondary to pneumonia, primary pleuritis, will not go into that. Any other cause of chest pain besides these 3-4 in
Local
children?
trauma, kyphosis,
Muscular, so musculoskeletal.
costochondritis, cartilage involvement.
Okay.
Severe pain on the left side of few days duration, only a horizontal line. Severe pain. Little older
HSV
child.
involvement.
Yeah, it
If
is coming
it
from
is-
axilla towards my nipple.
If it is a herpes zoster involvement.
Very good.
Zoster.
Very good. So before the vesicles you could get pain there, and that time you don't know what's happening. Okay. So now we've analyzed this child as possibly a cardiac case. So in which cardiac cases would you get chest pain in children?
Pericarditis.
Okay, pericarditis. So now this pain has been there for how long? As in how many days?
Pain is intermittent in nature since 5 years of age only. It
Okay,
is
so we
not-
can't be pericarditis for 5 years. What else?
Valvular stenotic lesions. Mitral stenosis.
So is chest pain common in mitral stenosis? I don't think it's a common symptom of mitral stenosis.
What is the cause of chest pain? Sorry, I missed a few things.
We just discussed
physiology, pathophysiology of chest pain.
in cardiac, no? We are still coming to that.
sorry.
So we are first asking ki if it is cardiac, what could it be, and then what Tushar is asking. So someone said pericarditis, and we said this is going on too long, so it's not pericarditis.
Any other non-cardiac causes of chest pain? Physiology? Pathophysiology?
One they said esophagitis, pleural, all that.
Costochondritis.
Costochondritis.
Sorry.
Ischemic pain.
Okay. So ischemic pain when and where? Where means in what situation?
On exertion, it's due to the decreased perfusion from the coronaries to the
Very
muscle.
good. Very good. So this is
Cardiac muscle.
specific to which condition? More
Aortic
common
stenosis. Aortic stenosis.
or Al Kappa. Okay. In aortic also, in stenosis or in regurg?
Blood flow will
So when are the coronaries perfused?
during diastole.
Diastole.
And what happens in regurg in diastole? There's a peripheral runoff, right? So it can happen even in regurg.
One of the common method of mode of presentation of aortic stenosis is what?
Syncope.
Syncope, and one should be really worried about it because it can result in sudden death in an individual, especially somebody has. Why can't it be vasovagal syncope? How will you distinguish cardiac syncope from vasovagal syncope?
It will be sudden onset, not progressing so much.
Both are sudden onset. He gave me an injection, I fell down. Sudden onset.
But the background history of all this.
We don't know. What will be when I am running, dancing, swimming? Will I get a vasovagal syncope? Never. When I have tachycardia, I will never get it. While when I am playing, aortic stenosis is more likely. So exertion, syncope on exertion is risky, and maybe due to I have known 2 individuals who have died suddenly while playing. They were diagnosed aortic stenosis. Surgery was advised. Surgery was delayed. While playing, he got a chest pain and he fell down and died. So aortic stenosis is to be kept in mind. risky.
Red flags for syncope, since sir said just complete the list. Red flags in a child with
Syncope child.
syncope child, red flags. When will you think it is not a simple vasovagal? You should first of all never say it's only simple vasovagal. According to me, it's not evidence based. Any child with syncope should have at least an ECG done.
No, it is evidence based.
Evidence based.
So a very good history, a confident clinical examination, and an ECG. If these three are normal, you have a good 95-96% sensitivity of calling it non-cardiac.
So what on history would you look for to confirm that it is vasovagal?
Change in
precipitate-
position, has this sudden change in position.
Okay.
Any associated illness, like for example, in adolescents, it's pretty common when they have fever and early in the morning when they usually bend down during
What
brushing
else?
it.
Syncope
Regain
at
of
rest.
consciousness.
Syncope
Sorry?
at rest will more
Syncope
like
at rest. Very good. Syncope in sitting position. Okay. Family history of cardiac deaths or anybody requiring pacemaker in the immediate family, or young death below 50 or 55 without any evident cause, any other evident cause. So cardiac cause. All these are considered high risk for evaluating further.
So this you said is either mitral or aortic, and in case that chest pain is to be given some importance, then between the two it little bit favors aortic more than mitral. Okay. The long history, does it favor any of the two? It's been 5-6 years of history, so does that favor any of the two? Maybe mitral, because mitral goes on for a long time. Okay, fine. Next. Now blood in sputum. So actually you've said that while sleeping, staining the cheek and pillow.
So actually, the mother told that they noticed blood when the child is sleeping, and it only stains the cheeks, and the staining of the pillow is present. Per se, blood in sputum is not present. As in, when he coughs and all, there is no blood in sputum. Only during the sleeping time, they notice that there is extravasation of the
Correct. So you shouldn't be, because this way if you put in the exam you will be taken for a ride. So you have to, now suppose you say what it is actually, that they saw this staining of the pillow. So now it may not be from the sputum. So now what all can this be? Child is sleeping and there is some blood trickling from his mouth.
Commonest?
Local
Local
causes
bleeds.
like gum bleeding,
Like
gum bleeding, dental.
Postnasal drip. Like
postnasal drip causing blood, why?
Like epistaxis.
Okay, so epistaxis. Then what else?
gum bleed.
Okay, gum bleed. So commonest cause of gum bleed? Scurvy is commonest. That's why I asked. I wanted to pull you into a hole.
Local trauma.
Still commoner. Commonest cause of gum bleeds.
While brushing was trauma.
Teeth grinding never causes bleeding. So bad hygiene, okay? Poor hygiene, infected gums, all that is the most common. Followed by your little bit trauma during brushing and all, and then come your uncommon scurvy and all that. Okay? Fine, so that is one. What else? Could it be hematemesis which is brought out in sleep?
Could be. Can be, but there are no associated any abdominal. There are no associated any abdominal complaints.
Okay. So does hematemesis just trickle out of the mouth like this?
The child is still sleeping with hematemesis.
So hematemesis is a prominent event. You know, the child will absolutely get up and have a proper vomit. It won't just trickle out of the mouth like this, right?
So could it be ITP?
You tell me.
It is a painless form of bleed. Child may not notice. It could one of the signs.
Yeah, so now tell me what is the commonest presentation of ITP that you've seen?
Petty over the lower limbs.
Okay, so petty or purpuric spots on the body. How many ITPs have you seen with blood from the mouth? So as in, after they have those hundreds of petechiae and they have bleeding gums, that time it's different. They may sleep and trickle some blood, but not as a first presentation. Okay? Okay. So, how do you know this could be sputum? What questions did you ask?
This was actually not sputum.
Okay, so is this child coughing?
No.
He's not coughing. So then this is not sputum. If it was sputum, you had anything particular in mind?
Cox.
Yeah, so first and foremost is tuberculosis. Now in this child, what will you have in mind?
Pink frothy sputum we should ask for.
Pink frothy sputum. Why?
It's a heart disease, so like we should think about left ventricular failure, pulmonary congestion.
I think that's more of a symptom in adults than in children. You're right, cardiac failure, pulmonary edema, pink frothy sputum, but more of adults, I think.
In the acute stage.
Huh.
In the acute stage, he would be coughing and bringing up froth and sputum.
Some malignancy.
Okay. So basically you'll have to divide into cardiac and respiratory. If it is respiratory, your cox is there, and then of course malignancy. And if it's cardiac, then can any cardiac conditions cause hemoptysis?
Mitral stenosis, because of rupture of this bronchial veins, it can cause hemoptysis.
So it is known in mitral valve disease in the long run in older children and young adults and all that, right? Okay.
In the respiratory disease, one other condition, though extremely rare with hemoptysis, think about depositional disorders like pulmonary hemosiderosis, etc. And
Okay.
what used to be called as Wegener's, now called GPA.
Just explain all the negative histories.
Fever, rash, joint pain for any rheumatic involvement. Recurrent
So
cough.
since it's not there, rheumatic is ruled out.
No.
So if it is there, it helps, but if it's not there, it doesn't rule out.
Any recurrent cough and cold means pointing towards pulmonary blood flow if there is pulmonary plethora. So there will be more chances of increased respiratory tract infections. Vomiting, abdominal pain and abnormal bowel movements, any for esophagitis like cause, if it is causing for the hemoptysis type, for that I had asked. Local trauma or dental procedure for again the bleeding. Blood loss from any other site, bluish discoloration of skin for any cyanotic episodes in the past, swelling of a body for any feature suggestive of CCF like pedal edema, cox contact, and sudden death in family for any HOCM type, because it is a adolescent.
Okay. Fine. So
just one other thing is, though you should have symptoms before that, but certain conditions where isomerization occurs in an acyanotic child, though there is no cyanosis currently also, but that could be one of the other congenital conditions that we didn't touch upon. To have a stormy presentation little later, who have survived up to a point without any surgical intervention.
So now tell us what is your thought process finally on history.
This is a 11-year-old boy, birth and developmentally normal, immunized till date, with complaints of progressively increasing breathlessness, chest pain and palpitations, probably a cardiovascular system involvement with features suggestive of congestive cardiac failure. Differentials could be valvular lesions, rheumatic heart disease, arrhythmias can be there, TB, pericarditis, cardiomyopathies, and lastly could be vascular diseases, collagen vascular diseases.
So first one we have already discussed. Second
Right.
one you tell us. Why arrhythmias in this child are you thinking of?
Because of the episodic chest pain and palpitations and
But you didn't get a history of episodic palpitations.
that was more on exertion.
Correct. So it was directly linked to exertion. That is different from episodic. What is episodic? He's sitting and suddenly starts and then suddenly stops. Right? So you shouldn't bring in arrhythmias as a differential here. Like arrhythmias can be a additional complication of an original valvular heart disease. That also, so far your history doesn't tell you that that exists in this child. And the whole 5-6 year problem cannot be explained on arrhythmia. So arrhythmia cannot be a differential. Okay? Then TB pericarditis. What do you all think?
So this is progressive over 5 years. There would be many other features of TB as well, rather than just weight loss, fever, any history. And this over 5 years, it's difficult to fit into the history.
You have now hemoptysis also, no? You said hemoptysis. So pericarditis with hemoptysis. Even better.
So hemoptysis makes it TB and the breathlessness makes it pericarditis. So TB pericarditis.
And what kind of pericarditis? Constrictive or tuberculous pleural effusion?
Constrictive.
Sir, we'll ask
Constrictive.
them. We'll ask them for a change. Chalo. Constrictive pericarditis or tuberculous pleural effusion, or you want to argue against both? Chalo, quick.
Sir, there will be signs of right-sided heart failure or
In,
constrictive pericarditis,
like,
ascites,
okay,
hepatomegaly.
ascites or,
Raised JVP, hepatomegaly.
which are signs which we have still coming to. Symptoms?
Symptoms of abdo-distension.
So pericarditis will have more of acute presentation, like acute chest pain which increases more on the bending forward. So
True, so that is acute pericarditis. As Khare sir is saying, this may not be acute pericarditis, it may be constrictive pericarditis, it happens over a period of time. So what will be the symptoms there? Come on. So there can be breathlessness on exertion. There could be edema feet, which is not there here in this child. But there is unlikely to be palpitations in that, right? In constrictive pericarditis or even in a pericardial effusion. So palpitation history goes against these two. So that is one. Then of course your 5-year period, right? And then of course no evidence of or no history suggestive of TB elsewhere and things like that. Okay. What about cardiomyopathy?
What type of cardiomyopathy, if at all?
Dilated, more of volume overload,
Okay, why?
increased precordial activity, increased chest activity over the chest wall. Then palpitations is also and
So young child, hypertrophic cardiomyopathy, hypertrophic obstructive cardiomyopathy, increase chest pain increasing on exertion.
So both of you have argued for one each, one for hypertrophic, one for dilated. Now I don't know too much about, I have not seen too many of them, but we said in the beginning that cardiomyopathy will keep it as a DD till we look at the examination findings, right?
Collagen vascular.
Why?
SLE and all, SLE and could have involvement of the coronaries. Like Kawasaki can also have involvement of coronaries, so that could present as chest pain and dyspnea on exertion.
5 years.
Chronic history rules set out.
So Kawasaki not chronic history of 5-6 years, no? So Kawasaki no. Collagen vascular, yeah, 5-6 years possible, but now complete the sentence. So okay, more in females then. Weight loss, fever, rash. What else?
other symptoms would predominate over cardiac symptoms.
If not predominate, at least they have to be there. Na? In over 5 years, the disease has to evolve into multi-system inflammatory. So it can't just remain confined to the cardiac symptomatology. So less likely collagen, right? So finally in your DDs, what will you keep? Valvular lesions.
Tuberculous pericarditis, constrictive pericarditis could be there.
Valvular lesions, you can keep cardiomyopathy and remove the other three. Okay?
This, cardiomyopathy was dilated versus HOCM. Just on history, if you are talking about, one simple thing to remember would be that dilated cardiomyopathy have chronic symptoms, whereas HOCMs are relatively asymptomatic, but they have catastrophe, usually, at least at this age for sure, or even bigger. All the HOCM accidents that you have heard, say in the gym or on the playground, etc., are much bigger children than 5-year-olds or 6-year-olds. Okay, so they take that much time to become critical HOCM, and then subsequent sudden crisis.
The child is here, no?
Yes, sir.
Yeah. So we'll first examine and then you present your findings.
You can just get the child without the mother if she allows.
You know the child? Which resident is? इकडे इथे बस ना चप्पल काढ याच्यावर पाय चढून चलो 2 volunteers to examine. Chalo, one more. Come, one more. First, just talk of your inspection findings. Start from make that habit. So, what all you want to speak?
The child is thin built, looks active and alert. He's slightly breathless, but he's tachypnic.
So, what is the difference between tachypnea and breathlessness? I thought they are same, no? Tachypnea is a medical word. Breathlessness is a layman's word.
Tachypnea just refers to the rate. Fast breathing is tachypnea. Breathlessness is more related to the work of breathing. And breathlessness is a subjective symptom. Tachypnea is an objective finding.
Okay, and what is dyspnea?
Difficulty in breathing.
Dyspnea is a medical term for breathlessness. Difficulty in breathing.
Difficulty in breathing as per se, he should be breathless visibly. He is finding it difficult to breathe, more subjective. Little more than just a tachypnea. Now here he is tachypnic obviously. Are there any signs of increased work of breathing? Can you look at his
There's
nose?
mild suprasternal retraction also.
So actually in the exam you should be careful and you should say, I will first undress the shirt and then decide. Don't just answer yes or no without seeing whether there's increased work of breathing or no. See it properly.
Is there a nasal flare?
Yes. Mild. But he looks comfortable though he is having efforts of breathing.
So what does that mean? You are saying
compensated.
very good. So it is chronic and compensated. Okay. Then, so now you know that your focus is on the cardiovascular system. We've discussed all that history. Keeping that in mind, on inspection, what all do you want to look at more and impress the examiner? That I am searching for all this, even on inspection.
Foot for pedal edema.
Very good. Foot for pedal edema. Then?
Clubbing.
Very good. Clubbing. Then?
JVP. Raised
Okay,
JVP.
so you're looking for JVP. Then?
Precordium mainly.
Yeah, which you have not yet opened the shirt. Then?
His eyelids are puffy.
There is puffiness, mild puffiness.
Maybe, we don't know his normal appearance, but it's an observation.
Then? Come on, what all? What more? Just on this much inspection, this much what you can see in the child.
Facies.
Very good. So you faces, so no dysmorphic faces. Then? Huh? Pallor. Very good. Then? Icterus. Relevant in a higher cyanotic heart disease or in a heart disease? But even they are not clinically icteric. So, what is next? Cyanosis. So, what's taking you so long? So, no cyanosis. Okay? Fine. So, see all this. Now, if you say all this, dhad on inspection, you already pass. Okay? Chal, now start further. You want him to ask him to open his shirt?
Do you want to do P-GALs in this patient? Do you want to do P-GALs examination in this patient? Yes or no? Don't want to do, I am okay. No? She's saying
No, sir, it's not a rheumatology case. So
Yes.
we are not doing.
So when do you do P-GALs? Okay, very good. Joint pains.
So what are the aims of P-GALs? What is the purpose of doing P-GALs? If somebody is complaining of right knee joint pain, you might as well examine the right knee joint. Now why do P-GALs?
You want to screen the other joints and the spine, and you want to see the gait.
So you want to pick up subtle abnormalities which they are not upfront complaining. So now you want to revisit Tushar's question, do you want to do P-GALs in this child?
I am offended, you said no. I'm standing in one corner. So you say if it was an acute rheumatic presentation, you would definitely want to do P-GALs. This is a chronic case with no evidence of fever or joint pain, so you may not do. But what if I tell you that there was rheumatic before, so there will be some joint deformity, something there, you don't want to check?
We were waiting for you all to fight with us on that, but you are not.
Trick question. Alert.
So what are the differences between rheumatic joint and rheumatoid joint?
Rheumatic heart disease will not cause any change, deformity.
So rheumatic joint disease does not leave behind residual.
On inspection of precordium,
On an average, you get 5 to 10 minutes to do an examination. So when you are up here, multiply this by so many people who are sitting here. Even if you miss something, it's okay. Just do it how you do it in the wards. Don't worry about it.
trachea appears midline. Apical impulse is seen in the fourth intercostal space in
So
mid-clavicular
we
line.
understand that we would prefer this patient to be lying down and you are examining from the side. But since we don't have the mattress today, so we are going to make him sit and you examine this way.
The chest looks a little asymmetrical.
There is a bulge in the left side, precordial bulge.
What else?
And pulsation is seen in the third left intercostal space, just to the left of the sternum, sternal border.
Is there any wasting? I thought that his muscles are, as if they are. This is little more prominent. Here you see the muscle there. It looks little thinner as compared to his body in general. Okay. Bulging test, left precordial prominence, correct? Any excessive pulsations that you see, aberrant pulsations, वर बघ बाळा, तिकडे बघा. Suprasternal. No.
So quickly when you are this was your inspection, you are done almost, right? Now palpation. So start palpation.
There is no clubbing and cyanosis.
Okay. Palpation, quickly, one of you. Keep the mic. Give the mic here.
The apex beat is in the fifth intercostal space, and
Yeah, go on.
shifted. Shifted. Little to the right of the mid-clavicular line.
No, so you don't say shifted to the right of mid-clavicular line. So how do you put it?
Apex
You have
beat
to
is felt.
either inside the mid-clavicular line or outside the mid-clavicular line. That's what you say generally, right? So apex beat is left fifth intercostal space inside the mid-clavicular line, you are saying.
Yes.
Okay.
And now we can appreciate the epigastric pulsation as well.
We'll come to that. Now you complete the apex beat. So what do you want to talk about it further?
Thrill is felt.
First you have to tell the character of the apex beat, no? So broadly you speak of three characters. Either it is normal or three types of apex beat to avoid confusion. One is normal. Second, forceful and well sustained. And third, forceful and ill sustained. What is the second and third? Forceful well sustained is what? Heaving, seen in pressure overload. Forceful and ill sustained, hyperdynamic, seen in volume overload. Okay? So what is this apex beat?
You want him to turn on the other side? If you are examining from the right side, you can do that.
You are you want to go up and do it, or you want to do it from here? Chalo, now go up. So decide what is this? Forceful, ill sustained, forceful, well sustained, what is it? Or normal?
See, you can come closer. You can see it.
Forceful and well sustained.
Okay. Then now you talk about other pulsations. So what are you looking for specifically on palpation? You have to mention those findings, whether they are there or not there. So what are you looking for on palpation besides the apex beat which you have finished?
Any thrills?
Very good. So any thrill.
Thrill is there.
So where is the thrill?
Left fifth intercostal space.
Okay. Which area? Any particular area like a mitral or a tricuspid area?
Mitral.
Mitral area. So there's a thrill. Thrill is systolic or diastolic?
It is systolic.
Okay, so when someone asks you this question in the exam, how do you answer it with a lot of style? I'm asking you, thrill is systolic or diastolic? So you are doing something on the child and impressing the examiner, okay, look how I have found it is.
Comparing with the pulses.
Which pulse?
Carotid.
Carotid. So you can leave the mic. Here your one hand is blocked by the mic. So you put one hand on the carotid, feel the carotid and then say that okay, or even at the apex itself you can look at the uplift of the apex, but basically you have to decide that it is systolic or diastolic, right? Okay, then what else you want to look at?
In the exam, you would have already auscultated the patient, so you know where is the murmur. Murmur is systolic, thrill is systolic. Murmur is diastolic, thrill is diastolic. Okay.
What else? Palpation, there are some 2-3 things in the precordium which you just have to stock off. Parasternal heave, is there or not there? It's there. Okay, the pen is showing it very nicely. Okay, so parasternal heave is present. Then what else do you want to see on palpation? Come on, quick. Epigastric pulsations. Check whether they are there, and then next you will say they are best felt on the tip of the palpating thumb or the pulp of the palpating thumb. What does it make a difference? Come on. Tip is RV pulsation, pulp is aortic pulsation. Then second space, what do you want to palpate? P2. So that's called as diastolic shock. So look for P2 in the second space, it's palpable or not.
In the exam, if you are showing P2, not just don't put your hand overall, okay? Try to palpate the clavicle, then go down, then put it.
Okay, okay. Now percussion. So in percussion,
Even before you touch the heart, the pulsations outside the precordium should be seen first. You may miss something just on because you didn't palpate the pulse. It could be a collapsing pulse, it could be anacrotic pulse. You get an idea about circulation first. So before you go to the precordium, and in precordium or maybe just outside the precordium, don't forget to put a finger there in the suprasternal notch, because aortic pulsations will be felt best there. So concentrate on outside precordium, because on precordium you will never forget. You will always remember. This may slip your mind. BP bola? Blood pressure.
we said let them directly examine. So
Pulse is regular, sir. There is a component of collapsing pulse also.
(102/60). It is between 58 to 90th centile, taken in supine position in right upper limb.
So basically, like Tushar said, you have to correlate all your findings. So you would have taken your BP, you would have felt your pulse, and then you would have decided whether you want to call it collapsing or no. So for collapsing, what should the pulse pressure be? Wide. It should be wide pulse pressure, right? So this, at least this BP doesn't suggest that this is collapsing pulse. So far, whatever findings we have got, what do they mean? So what does parasternal heave mean?
Suggestive of a right ventricular hypertrophy.
And what does diastolic shock mean?
Correlates with increased pulmonary flow, pulmonary hypertension.
So both these findings suggest that there is pulmonary hypertension. Okay? What are auscultatory findings?
So we can hear a pansystolic murmur.
Heart sounds first.
S1, S2 is heard.
M1, your examinations should start with M1, then S2, then in S2 what is more prominent, P2 or A2. Okay? So comment on M1. First sound in mitral area. Normal increase split. Normal, okay. Then second sound, P2 and A2. Is the second sound split?
No. No, sir.
Not split, so it's a single second sound. Normally it is split, no?
But the split, we need to check it on inspiration
Okay.
with respiration.
What I mean is when you start like that, don't suddenly jump on murmur. Start with this.
Pansystolic murmur, which is best heard in the mitral area. It's heard in other areas as well, but best heard in mitral area.
Conducted, not conducted? Is it conducted to other areas? If it is conducted, it is conduction or radiation? If the murmur is produced here and if I am able to hear it here, maybe here also, then I will ask you whether it is conducted or radiated. What is conducted? It just gets transmitted. And what is radiated? Along the flow of the
blood.
abnormal flow of the blood. So when it is radiated, the strength or the murmur characteristic remain the same, while if it is conducted, then they decrease as you go away from the murmur. Okay. So it tells you the flow in which direct regurgitation is taking place.
Child is thin built, conscious, cooperative and well oriented in time, place and person. Is afebrile, pulse rate of 82 beats per minute, regular, normal in rhythm, normovolumic, no radio-radial or radio-femoral delay. All the peripheral pulses are well felt. Respiratory rate of 34 per minute, thoracic 34.
Sir, here it's
Biomass. Room air saturation 99%, blood pressure 102 by 60 millimeters of mercury, which is between 58 to 98 centile for the child's age, taken in supine position in right upper limb. JVP of 2 centimeter of water, which is normal. Anthropometrically wise, the child is severe thin. Head to toe examination, head is normal in shape and size, no obvious facial dysmorphism, ears, nose, eyes are normal, throat is normal, chest Apex impulse is seen in the left sixth intercostal space, lateral to the midclavicular line. Limbs are normal. There is no pedal edema. Abdomen, back and spine is normal. Genitals are normal.
So this apex impulse means what?
The lowermost and the outermost part of the heart.
Interpretation of this finding that it is in the sixth space lateral to the midclavicular.
It is not in the normal position, means indicating cardiomegaly is present.
Very good. So it indicates cardiomegaly is present. Now, which chamber?
Left sided. Out. If it is only out, then it is right ventricular. If it is out and down, it is more
So
likely
this
left
is down
ventricular.
or it's not down?
Down.
Down.
Out
So
and
out.
down, so left sided.
So now the important thing is that when you are examining, suppose you said it is inside the midclavicular line, think what it means. So if it is inside the midclavicular line, it means no cardiomegaly. Now in this story, in this history, do you expect cardiomegaly or no?
Yes.
You expect. So then check your finding again, am I right? Okay, so this is the correct thing. It is outside the midclavicular line, but we learn with practice. But that's the way to think. That's why don't just collect findings. Keep thinking about every finding, what it means. So it will tell you, oh, why this, that way. Go on.
Systemic examination, cardiovascular system. On inspection, the chest wall is symmetrical, precordial bulge is present, visible pulsations are present on the left side of chest, apical impulse is seen in the sixth intercostal space, lateral to the midclavicular line.
Okay, so precordial bulge means what? Interpretation.
Cardiomegaly, indirect way of cardiomegaly.
So today I get a myocarditis and a dilated cardiomegaly, I'll get precordial bulge.
Chronicity.
Chronic.
Long standing, even
Long-standing
when your
chronicity.
chest is developing.
Okay, then visible pulsations mean what?
Increased precordial activity along with the
So hyperdynamic circulation. Very good, go on.
On palpation, the inspectory findings are confirmed. On palpation, the apex beat is felt in the left 7th intercostal space, 1.5 centimeter lateral to the midclavicular line, which is sustained in nature. Hyperdynamic thrill is present. Parasternal heave of grade 3 is present in the left parasternal area.
Okay, one sec. What is hyperdynamic thrill? Means I'm not familiar with this term, that's why I'm asking.
We know of hyperdynamic apex,
Hyperdynamic
but we
apex.
don't know hyperdynamic thrill.
Hyperdynamic apex and thrill is
Yeah.
present.
Okay.
How do
So
you,
now again.
how do you grade parasternal heave?
So grade 1, grade 2, grade 3. Grade 1 is it is seen but it is not felt. Grade 2 it is felt and it can be obliterated. Grade 3 it is felt and it is not obliterable.
Good. Now again interpretation.
All these things you have told, what is the aim of finding all that? Hypertrophy, dilated, outside the umbilical, what are you aiming at?
So you already said that outside MCL means it's enlarged. Okay.
So there is cardiomegaly. The cardiomegaly is contributed to by what? Which ventricle?
Left ventricle or left side of the heart in this case.
Is there parasternal heave also?
Yes.
Does
it is
that
present.
mean RV also?
Yes.
So both
Both
LV,
both
so there is
chambers are
cardio. Here you want to construct the diagnosis. This is our popular, very favorite term. You want to construct the diagnosis. So for constructing diagnosis, you must know where the heart lies, etc. But that's obviously on the left side. How big is the heart? And what has contributed to the size of the heart? Which ventricle is hypertrophy? For example, if I have a big LV, I know obviously it's not a mitral stenosis. Okay, so construct to here, heart is big, both the ventricles are contributing to the enlargement of the heart. Both left ventricle and right ventricle are hypertrophied. So if it is left ventricular hypertrophy, the lesion has to be, if it is in the mitral valve, it has to be mitral regurg. If it is otherwise, it has to be aortic stenosis or regurg. And what does it mean when you say the RV also? That means all this being transmitted through the pulmonary circulation to the right side of the heart. And what is the sign of pulmonary circulation being affected? She said that there is pulmonary hypertension. The second sound is loud and split. So you have constructed bilateral ventricular hypertrophy, pulmonary hypertension affecting the left as well as the right ventricle. Am I right? Yes. So this is how you construct. Then lastly, which valve is involved? Now without telling also, you know which valve is involved and what kind of it. It cannot be MS. It has to be aortic. It cannot be only isolated right side. So you almost have the diagnosis. Okay. Sorry, Dr. Rajesh.
No, sir. So, go on.
On auscultation, first and second heart sounds are normal. A high-pitched pansystolic murmur of grade
Okay,
5.
so hold on. So, you said they are normal and they may be normal, but if you are going to propose a diagnosis of mitral regurg in this child, then first heart sound can be what? Dash. Soft. So be careful whether it's normal or soft. So think about it. Okay? Then generally, see, this is a contradiction. S1, S2 normal and then loud P2 in pulmonary area. So by convention, you talk of the first heart sound in the mitral area. And by convention, you talk of the second heart sound in the pulmonary area. So you say only that the first heart sound as auscultated in the mitral area is either normal or soft or loud. Soft is MR, loud is MS, and normal is normal. Okay? Second heart sound as auscultated in the pulmonary area is normal or loud with split, with normal split, narrow split, wide split, split not heard, single, whatever.
And if there is a loud sound out of A2 and P2, what is contributing? Which is loud?
Next.
Okay.
Aortic area?
No, the murmur, you've said high-pitched, pansystolic murmur, grade 5, best heard with the diaphragm, conducting to the axilla. Any other, some 7 characteristics? Now we've got 5 here. Anything more you want to? Whether it's
Better
changing
heard.
with position or respiration. It's this just for completion's sake in the exam to again be complete and impress.
And
Okay.
characteristic of a murmur. VSD murmur is also pansystolic. This is also pansystolic. Can you qualify? Character? Rumbling pansystolic murmur is seen in VSD.
VSD.
Here the murmur is not so harsh as in VSD.
Okay, go on.
Other system examinations are within normal limits. Respiratory system, air entry bilaterally equal, no adventitious sounds. Abdominal system, soft and non-tender, no organomegaly. Central
What are you
nervous system.
specifically looking for in the RS? Basal crepitations and sometimes.
Cardiac wheezing.
Okay. So one more.
Pleural effusions.
Okay. Anything more?
Any collaterals?
Right? So you look for all that. Then what is looking for in the abdominal system?
Hepatomegaly,
For
right-sided congestive heart failure.
hand. And you are looking for what?
Ascites and hepatojugular reflux.
Okay, and dilated veins for what? Obstruction to the inferior vena cava or the vena cava system. Okay, then what else? Epigastric pulsation we talked of in CVS. What else?
Abdominal wall edema, if there is.
You're bringing in all chota chota and you're not saying the main big thing which is written on the board. Spleen, abdominal system, you're looking for the spleen, no? What is the connection to a CVS case? Bacterial endocarditis. So spleen is important in a CVS case. Okay? Okay, then CNS. Fine. So now, as sir has already done it, but you justify your diagnosis. Tell us what is your diagnosis and then we'll...
So this is a 11-year-old boy, birth and developmentally normal, completely immunized till date, probably a case of acyanotic heart disease with pansystolic murmur and loud P2, with increased pulmonary blood flow and features suggestive of congestive cardiac failure, with pulmonary hypertension, likely to be a regurgitant valvular lesion of the left side of the heart, or a septal defect could be there.
So now one is that in such a cardiac case, what is this constructed diagnosis? What should it consist of? It should consist of the summary of your history. Okay? So completely immunized till date, who presented with. Now in 3-4 words start compressing that whole history. So what will you say that whole history is compressed into what?
Dyspnea on exertion.
Progressive breathlessness on exertion. Progressive over what time?
Over a period of 5.
Spanning over 5-6 years. With, what did he have?
Palpitations and chest pain.
With palpitations and chest pain. With signs of, what are the signs? Conclusion of your signs. With signs suggestive of biventricular hypertrophy. With pulmonary hypertension. With what is the importance of a thrill? Suppose you have the same signs but no thrill, and suppose you have a thrill. What difference does it make besides the grade of the murmur? Come on.
What does thrill tell you?
You are thrilled if there is a thrill. Thrill tells you that...
Severity of the lesion.
Huh?
Severity of the lesion.
More than that, it tells you that the defect which is giving rise to all this is anatomically underlying that area. That is the importance of a thrill. So if you don't have a thrill, someone will argue with you, why can't this be tricuspid regurg? Why can't this be ventricular septal defect, as you already said? But when you say there is a thrill, and you say the thrill is in the mitral area, you can't have a VSD with a thrill in the mitral area. It has to be left parasternal. So that becomes a very big, easy differentiating point. Okay? So the importance of the thrill is that the structure, the abnormal structure, is anatomically under that area. Right? So when you will say all this, that progressive breathlessness on exertion spanning over 5-6 years.
Associated with chest pain and palpitations. With signs of bilateral ventricular involvement. With thrill present in the mitral area.
And
With the
diastolic overload of the left ventricle.
diastolic.
Okay. Because you had a hyperdynamic apex.
Without. Now you are finally going to give a diagnosis of what?
Complications.
No. You're going to give a diagnosis of valvular heart disease. Which valve?
Mitral valve.
Which etiology?
Regurgitant lesion.
Regurg is pathology. Etiology?
Rheumatic.
Rheumatic. So because you are giving a rheumatic, you will say that there is without any history of joint or involvement or fever, because you are saying that, but still you will justify that this is rheumatic, why it is rheumatic. Okay? And then complications. So after this you will say, suggest, so my final diagnosis is my rheumatic mitral regurgitation with pulmonary hypertension. Now you said congestive cardiac failure, right? You said somewhere. No?
Yes,
CCF.
Suggest your CCF.
So what are the signs of CCF in this child? Or what are the signs of CCF in general? Then we will talk whether they are there in this child or no. Breathlessness, okay, is a symptom of CCF. Are they there? No. Then edema, was it there? No. Tachycardia is non-specific.
There was not much of tachycardia. For a respiratory rate of 30 or heart rate was only 82. That means this child may have been, yeah.
Okay, then come on, it should all come in one breath. Signs of congestive cardiac failure. So JVP, basal
Fetal
Krebs,
edema.
hepatomegaly, edema, feet, none of them are there in this child, right? So you don't say congestive cardiac failure. When we say congestive cardiac failure, we mean right-sided failure. So sir had made that distinction in the beginning, right? Okay. And then in sinus rhythm, without evidence of bacterial endocarditis, that completes your cardiac diagnosis. Okay, all these 5-6 things should come.
Does this child have active carditis? And you said rheumatic origin. Does he have active carditis? How will you rule out in this particular child rheumatic activity present?
No history of fever.
Investigation. Chest pain can be one of the signs. Tachycardia.
So chest pain cannot be a sign of activity provided. So what will be that sign which will tell you that this is
Tachycardia.
not? So tachycardia be qualify. Which tachycardia? After he runs one floor.
Resting.
Sleeping pulse rate or sleeping tachycardia. Then chest pain के relation में tell me. Pericardial rub, telling you that there is active pericardial carditis. That is a sign of active rheumatic carditis. Then
Come on, you don't want to go home or what? What is the clinical sign for carditis? Horses gallop, no? Gallop.
incidentally, because Tushar talked of gallop, I remembered I auscultated this child. This child has a nice third art sound. So please, all of you, go and auscultate this child today. Please. Because you will get that finding. You will be able to make out what is a third art sound. It's easy to make out in this child. Okay? And then in future it will help you.
In the exam, don't stop short at constructing the cardiac diagnosis, okay? Because it's such a long and all the details are there. Still remember to say in a well-immunized, well-nourished child or whatever other things are missing. Because at the end of the day, you have to treat the child and the family and not just the cardiac condition.
So usually in exam you will be asked why not VSD or why not TR or something like that. So you will have to argue. Okay, about the site of the murmur, the thrill here makes it easy, right? And then plus minus all the other features, right?
As he said, VSD and MI are very close differential. Both have pansystolic murmur. Both have diastolic dysfunction of the LV. Both may present in a similar way. Lumbling murmur, conduction are small sounds, but they are important. In VSD, as he said, left paracardiac, left parasternal, it is conducted with that. First sound may be muffled. So they are close differential diagnosis because both have the same underlying pathology. One is because of shunt and another because of valvular dysfunction. But the problem it is exerting on heart is similar.
Okay. Go on.
Investigations were done. Chest X-ray was suggestive of cardiomegaly.
You have
With
the X-ray?
Yeah, I have the photo.
Okay, so
The CT ratio of 0.6.
should tell us what is this straightening of the left heart border. Can you show there and what it means? Anybody can show? Some seniors. Come. This is something which you have to learn and remember forever so that in exam you don't get troubled. Chalo. Show us the straightening of the left heart border.
So usually the cardiac silhouette, this area is what reflects the pulmonary artery. In a straightening of the left heart border, it means the pulmonary flow is increased, the pulmonary artery is enlarged. So instead of having this typical silhouette, we see a straight left heart border.
Very good. Excellent. You want to read the rest of the X-ray?
So start with this is a well centralized, well exposed X-ray. The bony shadows appear normal, and comment on the lung fields, and then the cardiac silhouette, and
So basically, okay, you want to read it further? No? Okay. So you will also, first you will talk of the cardiothoracic ratio. How will you measure that? Chalo, someone. Come. Show us cardiothoracic ratio.
In cardiothoracic ratio, first we have to see symmetry like spine in central. Then we will see the cardiac distance in between the total cardiac silhouette and then total thoracic. So in central and maximum diameter on the right side, and then we will take maximum diameter on left side. This one like A and B. A plus B is total cardiac, and then in the thoracic we will take this total distance. Ratio of A plus B divides by B, it will be cardiothoracic ratio.
Excellent. So what she said, and which is very important, is that the A plus B need not be in the same line. They can be upper niche. So you have to look at the maximum from the midline. Okay. So you look at the cardiothoracic ratio. Then you also comment on the right side of the right border of the heart as to how much it is projecting beyond the vertebral column. Why is that important? RV?
Atrial.
RA.
Right atrial.
Okay. So it will tell you about the right atrial enlargement also, which will again be very important in such a case, right?
2D echo was done, which was provisionally suggestive of severe mitral regurgitation with a left ventricular ejection fraction of 60%. CBC, a hemoglobin of 9.5, counts of 13,100, platelet of 4,06,000, hematocrit of 30.1, indices as 70.5, 22.2 and 31.6, ESR of 85, CRP of 4.6, ASO titers were negative. Throat swab, primary smear showed gram-positive cocci in pairs, gram-positive bacilli and gram-negative cocobacilli. The culture was no growth. Blood culture is no growth, and other parameters, LFT, RFT is also within normal limit. ECG was done, which was suggestive of left ventricular hypertrophy.
Okay. Anyone wants to say one or two things about the ECG? Why left ventricular hypertrophy? Why left ventricular hypertrophy?
That's by this Cololion criteria that the amplitude of the S wave in V1 and the amplitude of the R wave in V5 or V6 more than 35 millimeter. So that's LVH.
Okay, so that tall S and tall R, I mean deep S and tall R. Okay, then yeah, how do you make out the axis? So which leads do you look at for the axis? One? Why 1 and AVF? So 1 is what angle, what degree in axis, and AVF is what degree in axis?
1 is 0 degree and AVF is 90 degree.
Excellent. So 1 is 0, so like this. AVF is 90, so like this. So you have that one quadrant of that circle. Now you look at the amplitude in 1 and AVF and try and plot it. So what is the amplitude in 1? Positive or negative?
Positive.
Positive. In AVF? क्या चाहिए AVF? हाँ, last. Positive. So what is the axis? So in one, now what is the difference between the two, as in amplitudes?
AVF is more than
more, right? So the axis will be, you plot on this axis, let's say you plot whatever 5 or 6 units, and on this axis you plot 10 units, as is the amplitude. So you draw this thing. So what will you get? You will get about 70 or something, 70, 80, which is your axis in this child, which is normal, right? So this is the way to find out the axis on the ECG, right? Just by visually.
So done. The anti-failures first. So the child is.
Sorry?
Sir is asking about management.
Yeah,
If the
so
child-
chalo, management fatafat.
If the child is in failure, then we'll start. If the child is in failure, then we'll start diuretics, mean anti-failure management, diuretics to be started.
What else? So you should always classify. So what is the classification of management?
Resuscitation.
Immediate management, and then the definitive management, and then prevention of complications.
So immediate management is what you said, then definitive management.
Surgical management could be there.
Okay. Prevention of complications or prevention of recurrences till the time you get the child. What will you? You'll put him on for prophylaxis or no? Penicillin prophylaxis or no?
Yes or no?
No history of rheumatic, ASO negative. So why rheumatic?
leading cause of valvular disease in India.
Okay. And You might find something on echo, vegetations, etc., whatever, which may suggest, or you might find other findings, right? So rheumatic. So you will give penicillin prophylaxis. Okay? Fine.
Did we talk about indolent carditis? No. On echo, if you see carditis and not clinically, they tend to call it indolent carditis, and that's a sign of active rheumatic disease, and so the management becomes different. Okay.
So there are some differences in the new criteria between tropical our high incidence countries and other countries. So what are those differences?
In modified Jones criteria, fever of 38 degree, more than 38 degree is given as a +1. Arthralgia, polyarthralgia is also considered as a
Major criteria.
major criteria.
Where but
in tropical countries, polyarthralgia and not arthritis. Then
ESR more than 30.
so ESR 60 and 30. So in short, what they are trying to say is that in very loose words or conceptual words, the criteria are a little relaxed or a little lower to pick up a recurrence in countries where the incidence of rheumatic fever is high, right? So differences are ESR 60-30, then polyarthralgia being a major, and for a recurrence you could even use 3 minor and you need not have 1 major at all. Okay, so those are the differences.
First time and second time are different, and they are a little lax. You may not have major criteria when you have a recurrence of carditis. Okay, so as he said, 3 minor also will make that child has rheumatic activity or rheumatic carditis origin.
Okay, I think it's time, so we'll stop. Any questions? Okay, so now important thing is this was a good exam case to study. So all the residents, please examine this child in detail. Whatever findings we have discussed today, go back and examine those findings and understand so that you remember them for long. Okay? Okay. Thank you. Thank you to all our online viewers and online faculty for giving in their inputs. We meet once again next Thursday, 6 p.m. Thank you.